Good evening, everybody, and welcome to today's webinar on the management of aortic stenosis. Thanks for joining, and my name is Jason Brady from MedCPD, and I'll be your host for this evening's webinar. First, just a few housekeeping messages. If for some reason you cannot attend the whole session, a recording of tonight's webinar will be sent out to everyone who registered via email. Also, if you have any questions about how to mute your connection, or if you have any issues with audio or video, then I'd just encourage you to please send a chat message through to the panelists, and we will come back to you and work with you to try to sort that out for you. Look, if you do have any questions throughout the presentation this evening, we would encourage you to raise questions at any point through tonight's talk, and I'd invite you just to use the Q&A function at the bottom of your screen there. And if you just type your questions in there, we'll actually forward those through to Dr. Yudi through the presentation, and he can address those as we go. We'll also have some discussion time at the end of the presentation as well. So, so hopefully that will answer everybody's questions. Now, this evening, we are actually going to be running some polls as well through the presentation, just to check comprehension and make it a little bit more interactive. So we thought we'd just do a quick practice poll now. If we can have that on screen for everybody, please. So we just want to check that everyone's familiar with how to use the polls. And you should see a poll on your screen now with a question and a few options there. If you wouldn't mind just answering. Here we go. So what have you most enjoyed about stage 4 restrictions easing? It looks like indulging in your love for travel and decent coffee are at the top of the list there. Only one very brave person who said being able to escape my loving family. We did put the word loving in there just to make sure that there were no hard feelings there. So yeah, look, terrific. So it looks like everyone's fine with the polls. Thank you very much. Now, I think really that's all the housekeeping. Without any further ado, I'd love to introduce you to our speaker for this evening, Dr. Matias Yudi. Dr. Matias Yudi is an interventional cardiologist. He's a heart valve specialist, and he completed his fellowship in structural heart disease at Mount Sinai Heart in New York. And upon return to Australia, he has been appointed at Austin Health as the head of structural heart and the valve program that they have there. So we're really honoured to have him speaking to us this evening. And without further ado, Dr. Yudi, over to you.
Oh, brilliant. Thank you, Jason, for that very kind introduction. And thanks everybody for joining in today, taking time out of your day to get into this webinar about something I'm very passionate about. And I just finished a case. I'm in a dodgy room at the back of a hospital. But thank you for having me in your rooms and in your practices today. And I want to talk to you about something that's really revolutionized cardiology in the last 10 years. And it's really becoming mainstream therapy for aortic stenosis. And look, like anything, I just want to talk to you about a case that's been brought to my attention probably about 3 months ago now, which is a case that I'm sure all of you see every day. So it's a 75-year-old gentleman who just presents with increasing shortness of breath on exertion. He's a high-functioning lawyer who's never going to give up practice. He used to smoke and drink quite a bit in the past, but now he's pretty well behaved. He's got cardiac issues, and he's had a previous PCI to the LAD. He's had a pacemaker in the past, and some risk factors that are usually pretty well controlled. You see him usually once a year, and it's you're surprised that he's come in early with breathlessness on exertion. He actually had a bit of a falling out with his cardiologist, so he wasn't really followed up from cardiac wise, but he was just seeing a very good GP that kept him going. Like a good GP, with breathlessness and the cardiac history, he did an echocardiogram, which you can see here. And, I'm not going to bore you with the details, but this is the ventricle, which appears to be functioning very well, but you've got quite significant calcium in this aortic valve. And this is something that we're seeing a little bit more closely in here, just to get you used to what an echocardiogram looks like. The white stuff here is really representative of calcium. Usually it's nice and thin and moves around pretty well. So you're pretty happy that the echo report comes back to you with these measurements. It's saying that the mean gradient is 52. You've got a small valve area of 0.7. The ventricular function is not as good as the last echo about 5 years ago. And there's significant left ventricular hypertrophy, but no other major valvular abnormalities. So after you've done this echocardiogram, I guess I want to just put it out to you as a poll, given how well you did with the previous poll. What would you do at this point with this guy? So you've got a 75-year-old lawyer who's got this, diagnosis now of severe aortic stenosis, and he's feeling breathless. I'll give you a couple of seconds to think about that, and then I'll let you know what happened in real life. So would you start making him feel better by starting him on frusemide, which is reasonable because it's likely that his breathlessness is pulmonary edema? Would you kind of repeat an echocardiogram in 6 months and see if the ventricle starts to get tired of the aortic stenosis? Would he go back to his usual cardiologist, or would you refer him to a surgeon or to a multidisciplinary heart valve team? Good. Look, and so refer to a cardiologist. Oh, what a great audience. This is great. Look, what happened is that this guy didn't get on that well with his cardiologist. And the GP said, look, it's a valve issue. I'm going to send you to a cardiothoracic surgeon, and you can go from there, which is not unreasonable. I think repeating an echo once you're symptomatic with severe AS is probably not the right thing to do. You need to get a bit of help. So in this context, I just want to bring you back to some very simple things about aortic stenosis, and particularly symptomatic severe aortic stenosis. And I think let's go to broad guidelines. And this, I just chose the American guidelines, but the American, the Australian, the European, they all say that if you've got a pretty healthy patient who now has severe valvular heart disease and they become symptomatic, they should always be considered for an intervention. So I think that's the number one key here, is that you've done the right thing. You've ordered the echo. They're symptomatic. I think it's time for them to think about what the options are available. And look, this is one of the graphs that I've fallen in love with. And I think I first saw this when I was a final year medical student, when I was thinking about obstetrics or cardiology, crazy roads that are diverged. But this is what happens with aortic stenosis once you become symptomatic. So you can do very well with asymptomatic aortic stenosis. And as it progresses, once you get symptoms, your prognosis is dismal. It's worse than cancer. So your average survival, if you have heart failure with aortic stenosis, is around 2 years. So 1 in 2 patients will be dead within 2 years if you don't do anything. And there's no medical therapy that we can do. We can't give them extra statins. We can't give them, diuretics, ACE inhibitors. All that stuff does not work with aortic stenosis. So that's really a key point, is that once you have symptoms, it is time to think about intervention. This is a slide that I borrowed when I was doing a talk in America, but it's really highlighting how common aortic stenosis is, and how in our population, both American and Australian population, is that there's lots of people that are going to develop aortic stenosis because it's a disease of getting old. And they're really going to different categories. Patients who are extremely high risk for surgery, those that are high risk, which is classified around a mortality rate with surgery of around 8%, intermediate, which is about 3 to 8%, or low risk, which those risks are around 3%. So it's a huge number of people, and they all fit into this pie in different in different sections of the pipe, depending on their risk. And that's why it is important to think about the patient as a whole, where they would lie in this spectrum. And look, I don't want to bore you with a lot of data, but I'm happy to talk about it offline or anytime. But I guess what happened here in TAVI is that we started this new technology against people that no one would operate on. And then we found that those people lived much longer with the intervention, even though they were highly frail, very old, and we only needed to treat 5 people to save 1 life. So that's what changed the paradigm. And then over the last decade, we started, testing in people that are high risk, who could either have surgery or a minimally invasive approach. And then intermediate risk. And only in the last 18 months, we've had data in people that are low risk. So really fit and healthy, 70-year-olds and 80-year-olds that have severe aortic stenosis who would, in most likelihood survive open heart surgery, but who have a potential other option. And the great news is that this technology has been shown to be as good, if not better, than surgery in terms of inpatient mortality, in terms of decreasing stroke rate, and increasing atrial fibrillation and renal failure. There are some caveats. The pacemaker risk is slightly higher, and we do get a little bit of complications from the legs, which is around 5% where we put these large tubes in place. But overall, the data is very, very encouraging, and is now a Class 1 indication in the United States and in Europe across all spectrum of risk. So in one of the latest papers that came out is that TAVI, or TAVR as they call it in America, may be the preferred treatment strategy to surgery in patients with aortic stenosis at any level of risk. And this is really what's changing the paradigm, that we're no longer thinking about aortic stenosis as a surgical disease, even though lots of patients can have surgery. It is a condition that is best managed in centers where we can provide the whole spectrum of treatment for aortic stenosis. Look, this all started in 2001, so nearly 20 years ago in France, when this guy who had cirrhosis was only given a couple of months to live, and he had critical aortic stenosis and couldn't get out of hospital with hypotension and pulmonary edema. So they tried this first device in place, and he survived, and he made it to over 12 months. And everyone think, oh, maybe we can do this long term, and that's the journey that TAVI has been on in the last decade. Now we have a very minimal invasive approach. We know once upon a time, even 5 years ago, we used to do it under general anesthetic with very careful transesophageal echocardiogram. Now it's all under minimal invasive sedation. And we go usually peripherally through the femoral arteries. And the procedure, we just finished one today, which wouldn't have gone from needle to skin till the time we finished. It wouldn't have been much more than 60 to 70 minutes. So it's really revolutionized treatment of this condition, which usually affects patients who are elderly and have multiple other comorbidities. Look, there's 2 main valves that are designed. And I guess what everyone asks is, if you're doing it minimally invasive, what happens to the old valve? And what you can see here is that the old valve gets pushed to the side. And given the sinus of Valsalva is quite a bulging structure, there's enough room for that old valve to be in there. And then you've got a nitinol frame, which is like a scaffold that's nice and strong, that opens up, and then you've got the valve leaflets inside, which you can see here in the white. And one of the common valves that we use that you can see here is that the leaflets are actually mounted much higher than the annulus, meaning that you're getting great hemodynamics, which means that the valve area after the procedure and the gradients are very low. And so far, we've got great data on its durability, up to 8 to 10 years. So there's been no sign that these valves are failing early. And this is something that we always want to keep an eye at when there is very new technology. Which really leads me to the crux of this talk. And this is what I really want to focus on for everyone out there in the community. And this is what I talk to residents and to general physicians and geriatricians, is that patients with aortic stenosis are complex, and the anatomy of the valve is complex, and other cardiac comorbidities is complex. So we really think that these patients do best when they become involved into a heart team. So it's not just one cardiologist making the call, or one surgeon making the call, or a geriatrician saying, look, this guy or girl is not good enough for any intervention. You know, and I think that that is not a decision, given the malignant cause of their condition, that is no one decision that one person should be able to make. So the evolution of TAVI has been that there's been formations of heart teams where a patient would come in and would get seen by, you know, a structural interventionist who does the procedure to really explain the nuances, but also by non-invasive cardiologists who may have some qualms about other cardiac conditions. The cardiac surgeons would also be involved, because there's certain anatomies that might not give them the best outcome. You know, if they've got significant coronary disease, again, you know, that patient would probably be better being fixed with bypass grafts and a valve rather than a TAVI and maybe inadequate stenting. So this is why it is so important that all the information is gathered and then be discussed. You know, and the case we had today was you know, not dissimilar to this guy, 76-year-old, pretty fit and well, but he was a heavy smoker. And then once we did some lung function tests, we found out that his FEV1 was very low, his DLCO, you know, his ventilated perfusion was about 26%. And his respiratory guy said, this guy's not going to do well with bypass surgery. He'll get through the operation, but he gets atelectasis, he'll have a pneumonia, then he'll have tracheostomy, and the whole works will just become a lot more complicated. So in that context, even though he was physically good enough to have surgery, his lungs wouldn't have been good enough in this case. You know, so the anaesthetist was very happy that he could just lightly put him to sleep while he maintained his own airway. And as we left CCU not long ago, he was sitting at, you know, 30 degrees, you know, breathing normally and talking, and he's having no major issues. And he'll be out of bed later tonight and first thing tomorrow. So this is so important to highlight, you know, that you know, just looking at the valve is not doing the patient the right service. It's not just doing a TAVI or just doing surgery. It's about thinking about all the potential issues and simplifying the life journey for that patient, both in the short term and also in the longer term, you know, if they're going to live another 10, 15 years. So the investigations are quite extensive. Obviously, patients usually get referred when they have an echocardiogram that's showing, you know, aortic stenosis of different severity. Some people get referred a little bit earlier, which is a great idea, because, you know, as we all know, is that sometimes you can have a patient who's got significant symptoms, but the echo doesn't quite match up, and there could be some technical issues with the echo, and it is a very operator dependent test. So you could actually underestimate if you don't get the right jet. So symptoms are very important. Everyone has an echo, an ECG, and the CT scan is very, very important to again measure the valve and ensure that anatomically these patients would be suitable for surgery or a TAVI. And, you know, there are patients who obviously are very short and wide, who surgery would not be a good option for them, because they would get significant patient prosthetic mismatch and would still feel breathless after putting a small valve in. So that's why it's important to assess everybody like you would do either procedure and then decide.
We have actually had a question come in.
Oh, wonderful. I love this.
How many TAVI patients get seen by a heart team?
Look, it's everybody that comes in that gets referred gets seen by at least 3 or 4 specialists. So whether they see the cardiologist, the cardiac surgeon, some people a geriatrician, some other people see the respiratory guys, they all see anesthetists, they all see the cardiac nurse. So in general, everybody sees pretty much everybody. And then they all get discussed in a multidisciplinary team. So then in that scenario, all the patient's imaging, the characteristics, and we actually film everybody walking up and down the corridor. So, if you haven't met that patient, you get a grasp of their frailty, how robust they are, and how they'll recover. So it's quite a robust process, but it's a great question. It's we want everyone to meet everyone almost individually. And then, for people that are involved in this team, there's some, sometimes we have multiple cardiologists. Not everyone would see them, but they obviously have an opinion based on what's presented. Hope that answers that question. Have we got any more questions?
Not at this stage.
Not at this stage.
Thanks.
Yeah. Feel free to butt in and keep Jason busy. So if you've got any questions at any time, just stop. So look, let's go back to this lawyer. So this lawyer was referred to a cardiac surgeon who said, look, you need an angiogram. He organized that by one of his colleagues. He's got no other significant coronary disease. If you go to a surgeon, or you go to a barber, you'll get a haircut, right? So the surgeon goes, look, you're a robust lawyer. I think you should have a surgical AVR. And then they talked about what that entails, the stenotomy, the post-operative period. And he goes, I've got a business to run. I can't take 4 weeks off and take 3 months to recover from my stenotomy. He plainly said, I don't really want to have open heart surgery. So I'll open up the discussion to you because this patient went to the cardiothoracic surgeon, and he wasn't as strong as he was in this statement. But once you got the letter from the cardiothoracic guy who said, yeah, we can do the surgery. But then this lawyer comes to see you and says, look, I don't really want to do surgery. Have we got a poll here, Jason, that we can put up? What would you do? Yeah, this is the 75-year-old lawyer. I'd love to hear your thoughts, because what would you do in your day-to-day practice here? Would you go to another cardiothoracic surgeon and see if he can talk him into it? Or, I guess I'm biased, but should you get him to a heart valve team? We'll give you a couple of minutes to... Well, a couple of seconds, a couple of minutes, that's a long time.
We've only got a couple of people who haven't answered.
Oh.
If you can get your answers in, and then we'll have a look at the results.
Perfect.
That might be everyone, I think. Here we go.
Let's have a look. Let's have a look. Good look. And the reason I put this one up, because it's all of those things is what people would do. And I think probably medical therapy aligned and surveillance is probably the least likely thing that would be good for this patient. But I think getting different opinions, given how bad the prognosis is, severe aortic stenosis in someone who's pretty fit and well, you might have a cardiologist who you work with very closely. It's important to get them involved, or another surgeon who may do different, minimally invasive thoracotomies that could offer him some options. But I think the key here, and I hope that I'm getting the point across, is that if you refer him to a multidisciplinary heart valve team, all those options will be put on the table and really discussed in a meeting where the patient's best short and long-term interests would be at play.
Dr. Yudi, we have had another question come in from Stan as well. He's asked, how do complication rates compare between open and TAVI?
Yeah, perfect. Great question. So look, the mortality rate, look, touch wood, the mortality rate that we've had since I've come back from overseas is 0 at 30 days. And so that's comparing to the surgical, which is about 3 to 5%, depending on the different surgeries. So from a mortality point of view, it's very safe. The international data is around 1% mortality at 30 days. The risk of stroke, it's around half of that of surgery. So it's around 5% for surgery and maybe 2 to 3 in TAVI. And they're the ones that I like to talk about to the patients because they're the most meaningful. The other outcomes that are important, you get more renal failure in surgery, you get more atrial fibrillation in surgery. With TAVI, you're more likely to have a pacemaker inserted, which is around 10%, and vascular complications because you're putting tubes in, large tubes, about 5mm tubes in your legs, usually of the subclavian. The rate is around 5%. Usually that's manageable either with compression, putting a stent or a balloon, and very rarely you get a vascular surgeon to put just a manual suture if you can't stop the bleeding. Pacemakers are something that I worry about, particularly in a younger population. 75 lawyer having a pacemaker wouldn't be an optimal outcome. But this morning we presented a patient who was 92, very robust, but he is very high risk for having a pacemaker, and everybody voted he should have a pacemaker first and then have his TAVI, just to make sure we don't have this complete heart block episode post-op and he becomes unstable. So the two things that aren't as good with TAVI is the pacemaker rate, and the other thing is aortic regurgitation. All right, so you get a better seal with surgery, and with the TAVI valve you get some regurgitation, which if it's mild or less, it has no prognostic significance, but moderate or more, which the rate is again around 1 to 2%, is not good prognostically and may lead to further interventions down the track. So that is the Achilles heel that we're working on. And that's what we do so much CT analysis to work out which patients, no matter how good a job you do, you're still going to get a leak. If they're surgical candidates, they should maybe have surgery. So great question there. So, and what else can I tell? I guess from a patient perspective, the thing is that these patients usually go home within 24 or 48 hours. They're sitting out of bed within 12 hours. So, the short-term outcome is much, much better than surgery, which, you go to ICU, you're intubated for up to a day, sometimes more, and your length of stay is much, much longer. So that's the pros and cons. Any other questions?
No other questions at this stage, thanks.
No. Thanks, guys. It's great to butt in. So this lawyer, so he doesn't have surgery. We know that he needs to have something done. I think that that's the most important thing that I want to get through to you. If you have someone with severe AS or getting close and getting symptomatic, we need to do something about it, or at least assess to see if that's an option for them. And I want to tell you that the face of TAVI is changing. All right. So once upon a time, this 75-year-old lawyer would have for sure got surgery, and there wouldn't have been no other option for him. Someone like this guy who becomes more symptomatic would have had surgery, but he refused, and he was back on stage within 4 weeks. So, and that was only done last year. So we're getting more fitter patients having TAVI because the outcomes are so very good. So I won't bore you with the guidelines, but I want to just say that the guidelines are changing, and they're incorporating both the minimally invasive TAVI and also incorporating the heart team model. All right, where we take everything into account, not just the valve. We take it to the patient, the anatomy, the short and long-term outcomes that we'll get with both, to give the patient the best outcome. The lawyer ended up getting referred to our site, which was great. We did a CT. You can clearly see this. You can see it much better than on the echo, that he's got severely calcified trileaflet aortic valve. So there's 3 cusps, the non-coronary, the right, and the left. So it's got a lot of calcium in there. So that's what's causing his valve not to function. He was quite anatomically suitable, so we're able to get a good approach into the ventricle that you're seeing in here. And he was consequently presented. He actually had 2 choices. He really could have had either one, but he met a surgeon before, and obviously his wishes were against. We discussed the pacemaker risk in particular with him, which is slightly higher, and he was willing to take that on, and he went home very quickly. I'll show you what usually happens, just to get a bit of an idea. This is an aortogram. So this is the aorta here. This is a pigtail that we use for a marker, and the black stuff's the contrast. And you can see again this heavily calcified aortic valve. Our lovely anaesthetist here has put a temporary pacing wire into the ventricle, and we use this for pacing. So when the valve gets deployed, the heart is not moving as much, so we can position it nice and appropriately where we want it to land. And this is what one of the valves look like. We're happy. It comes in a tube, and this tube is about 5 millimeters. So it goes through the leg. And then once we're in the right position, you open it up and it ends up looking like this. So you've pushed the old valve aside here, and you've got a functioning aortic valve with the leaflets that you can't see. You can't see them on X-ray, but it's a very good result. And this guy went home within 48 hours, and he's back doing his lawyer thing. That's one spectrum, and I just want to share this with you because this is one of the great stories since I've come back, is that we got referred this 98-year-old guy from Launceston, who was chopping wood his whole life, and his only symptom was that he could no longer chop wood. He was just so breathless, and his life was not worth living at that point. And so he was referred to a cardiologist in Launceston. I said, no, you're too old, Rexy. You can't have anything done. And then through some connections, that they ended up giving me a call, and the referring guy was great, because he sold me this story about a robust elderly gentleman who lives in a farm, 90 minutes from Launceston. And he didn't really tell me his age till I said, oh yeah, it's very, very reasonable. And then, so obviously when he became 98, it always raises some questions. And this is when the heart team became incredibly important, because everyone had their own biased views. And the geriatrician said, look, this guy, there is nothing that I can see that's going to cause his immediate downfall, apart from his aortic stenosis, which was critical. And we had to present him at 3 times, because there were some people that really said, this is not a good idea. But he had good supporters in Launceston, and the geriatrician was able to get him through this. I was only just got back from overseas, so I couldn't be too vocal about it. But they finally let us do him. And this is 2 years later. He's reached 100, and he had a nice article about him in the Examiner, and his whole family are very happy. So we'll keep him going, hopefully for a few more years. So the point of sharing that story with you is to say that age in itself is no barrier. If we can do Rexy, because he's so good for his age, and we've rejected people in their 70s, we have multi-organ failure. I think all patients should be considered on merit, and we should get a decision there. So look, I'll stop there, because I'd love to have a chat to you guys about what you think. about any of the things that we discussed today. And we've got even a few questions if you want to get your CME's worth. But is there any questions out there?
Okay, so there are a couple of questions here that we can just have a quick look at on the screen. One of those is, when and which patients should I refer for TAVI?
Yeah. Look, I'll rephrase that question, and is, when should I refer a patient for a heart team evaluation? So I think, first of all, if you've got someone who's got aortic stenosis, whether it's moderate or moderately severe, I think they should be linked in to a cardiologist or a center that has access to a multidisciplinary team where everyone works together to work out what's best for the patient. You may refer them for a TAVI, and after all this workup, you give them a call and say, look, I think in your best interest, you'd be better to have surgery. Or the other way around, you may be referred like this lawyer for surgery and end up saying, look, it's a valid option for you to have a TAVI. So I think the key is to think about aortic stenosis. And once you've got aortic stenosis, refer early and refer ideally to a place where all the options are available, not just TAVI, even though TAVI is going to become more and more mainstream, and it's going to become, the technology is getting so much better that now in America, really, if you're over 70, TAVI is really the number one option, unless you've got other issues like a bicuspid aortic valve or several severe coronary disease that would be best dealt with surgery, or other valves that would need to get fixed at the same time, where surgery would give you the whole package.
All right, that's great. And Matias, look, I'll just let you know, we've got questions coming in thick and fast at the moment.
Love it.
So look, another question is, how long does a TAVI last compared to open heart surgery?
Look, a great question. The data is very robust, up to 8 years. So we know the first patients that got this done about 15 years ago, they were all very elderly and sick for multiple reasons, and they died from other causes. There was no issue with the valves. Now that as we went to younger patients, we've got very good data to 8 years that you're not having to do repeat operations or repeat TAVI up to 8 years. And look, I think even though surgery's been around a long time, not all surgical valves have been studied as well as TAVI. And there's some valves that have come in the market, and then we found out 3-4 years that they're no good and they've been taken off the market. I'm pretty confident to say now that we've got great data with TAVI that, I'll say that within 8 to 10 years, if we get a good result up front, you're not going to be able to need another valve. So if you're 80, your life expectancy would be, 7-8 years. We think your TAVI valve would outlast you.
Okay, terrific. Look, there's another question here. Does TAVI require anticoagulation?
Great question. Great question. Look, I recruited for a study that looked at anticoagulation, putting Xarelto on people after the TAVI valves, and there was no benefit. There was no at all, but there was increased bleeding. So now that's been taken out. So if you've got an atrial fibrillation or you've had a recurrent PEs that you require anticoagulation, you continue that. But other than that, we send them home on aspirin and clopidogrel for a short period of time. And usually one agent is good enough long-term. And I've been transitioning now to people to aspirin after 4 weeks. Okay,
terrific. Actually, you were talking about the fact that age doesn't need to be a barrier. One of the questions we've had is, what is the youngest age for TAVI?
Yeah, look, that's a great question. Like I said, it's all about looking at the long-term outcome of the patient. So if you're a young guy, like Jason, he's sprightly, this guy. So if he had a severe aortic stenosis, it would be a congenital problem, and then a TAVI, giving you an 8-year reassurance is not going to be good enough for you. So I would say maybe a mechanical valve, which is going to last 30 years, would be where we need to head. So it's very individually based, But we have done people in their 60s because they've had multiple other comorbidities. We had one that was waiting a liver transplant and no one was going to do surgery on them. So we got them through so they can have their liver, and then, we'll see what happens down the track. But if you've got a good 20 plus years to go, I would still think that we need to think about surgery, and there's different surgical options, whether it's a mechanical valve, a Ross procedure. There's things that we need to think about.
Okay, now you just mentioned Ross procedure. So we had a question just come in about that as well. So I'll just read it as it was sent in because I'm not the specialist, you are. A 52-year-old male fitness instructor with a tight bicuspid valve had a Ross procedure followed by a protracted and complicated recovery. So can you just comment on the Ross procedure?
Yeah, look, the Ross procedure is a very technically challenging operation, one of the most technically challenging for a surgeon. So what they do is they take out the pulmonary valve and they put that in the aortic position, right? And then they put a bioprosthetic valve in the homograft in the pulmonary valve, because the pulmonary is a low pressure system. We think that that's not going to cause problems. So in the aortic position, now you have the pulmonary valve. The beauty of that is that you get great hemodynamics, you have the patient's own tissue, and you avoid anticoagulation, which is, for this fitness instructor, was probably the deal breaker, because the other option in that guy would have been a mechanical valve. And look, obviously I'm not sure who did the procedure or who does any procedures. I think in this very subspecialized world that we live in, you would want to go to a surgeon that does the most Ross procedures. They're not that common. And, in our institution, we've just dedicated one guy to do Ross procedures. And I think that's the same as happened at, Royal Melbourne, or, different places have different things. But, you need to go to a surgeon that specifically does it. Like anything, you can always, you always can have complications. I've had my complications. Everyone's got complications. So I don't know what happened in this case, but, it's great that he was thought about. The Ross procedure needs to be think about, and that's why it's important to have these robust discussions where all the options are on the table. You don't want to go to a surgeon who just does mechanical if Ross procedure is an option. And again, you don't want to go to someone that dabbles in Ross when there's an expert in Ross. So, yeah.
Okay, no, great answer. Thank you for that. Okay, so a couple more questions that we have at the moment. What happens to my patient after their TAVI?
Yeah, look, it's a great question. Like I think I've kind of alluded to today, is that guy, that we did today, he'll sit out of bed later today. He'll walk around tomorrow. He'll get a repeat ultrasound of the heart, get an echo to see how it's going. And pending how he's feeling, he could almost go home late tomorrow. This guy that I did lives in the country. He's very, he's robust enough. If he lived around the corner, we'd get him home, I think, tomorrow. But, our plan is to keep him in for 48 hours. Then we see them at 30 days with a repeat ultrasound. And what happened is that this valve continues to expand and adjust to the annulus. So you even get better hemodynamic results at that time. And then usually if they came from our institution, we go back to their cardiologist or whoever looks after them. And from our heart team, we see them once a year, again, looking at the ultrasound, making sure there's no valve deterioration or any faults that we can pick up early.
Okay, no, that sounds good. And what tests are required before having a TAVI procedure?
Great. Look, it's a great question. I think the minimal thing is that the actual test is the echocardiogram to confirm aortic stenosis. You do an angiogram to make sure there's no significant other coronary disease that may need to be dealt with at the same time. And then depending on the patient, like the guy we did, he needs a respiratory function test because he's a very heavy smoker. If they've had previous strokes, we want to have a look at their carotids, again, just to individualize that patient. And then everyone needs to have a CT TAVI. So that is, revolutionized cardiology. So the hardest part of the TAVI procedure is really the CT, really planning, seeing where all the obstacles are going to be and making sure that you're putting the right valve in the right patient. So, the CT is crucial. And, there are times when the CT has too many red flags. And I would say, look, I'm not going to get a good result. This guy should have surgery. So,
okay. Another one, how do post-procedural hemodynamics affect quality of life generally?
Yeah, look, this is a great question. And because patients don't stay in very long, and because they almost feel like it's it's a minimally invasive, you don't really think about having a big heart operation when it's done minimally invasive. They go back to their usual activities within a week. I encourage everyone to walk around very quickly, not to do any heavy lifting in the first week, and then go back to normal life and push yourselves, because the valve's in place, the vascular access has been completely resolved. So that's very reassuring. So they don't have the protracted period where they have to suffer before they get the benefits, like in the sternotomy, where you may be in hospital 7 to 10 days, then you may go to rehab, and your sternum may not heal properly, till up to 3 months. So all these issues, they're taken out of the picture, and quality of life is back, very quickly.
Okay. We've got one last question at this stage. If anyone else has any questions, I'd invite you just to type those in the Q&A for us now. The last question we have at the moment is there anyone who shouldn't have a TAVI?
Yeah, look, there is, without a doubt. But I think, again, that is not an individual decision. I think, like this 52-year-old gym instructor with bicuspid valve, he shouldn't have a TAVI. But the key here is that they should be discussed with all options on the table. So I think that's the key, is that there's, valve heart centers now where we need to be able to produce the best outcome with different individuals who have different expertise chipping in to work out the best deal for the patient.
Okay, thanks for that. There is actually another one. How has TAVI changed over time? Or I guess specifically over the last few years? Like when did it really, you were talking about the first procedure, like how has it developed over the last few years?
Yeah, look, unfortunately, I wasn't there when it first began, but it was, it's pretty hairy stuff, they tell me, because the tubes where they came in they were massive. Sometimes you couldn't put it in through the legs, so they'd go straight through the apex, and that would cause all kinds of other issues. So that's completely gone out of vogue. There was horrific complications from the legs where you couldn't stop bleeding. The technology has become smaller, easier to maneuver. And I think the game changer, as far as I'm concerned, even though it was before my era, has been the CT analysis. So once upon a time, you would do an echo and then kind of do some 2D measurements and trying to work out which valve to put in there. And sometimes, you're too small and they'd fly off. Sometimes they're too big and you rupture something. With the CT, you're very confident that you're going to pick the right valve, and those catastrophic complications have decreased significantly, and they're in the 1 in 1,000 kind of category. So I think the CT is the most important part, and that's what I tell all my fellows. I said, look, everyone can push a little tube up someone's leg and do these kind of things, but it's kind of the planning that's going to make sure that you don't run into any of those problems. So I would say CT.
Okay, that's interesting. So look, there is another question here. Who looks after the patient after the TAVI treatment, cardiologist-wise?
Yeah, look, in my patient, in the patients where I do the procedure, I like to look after them, But we've got a team at the Austin. We've got a structural fellow that rounds on all these patients before and after, and obviously keeps you updated if there's anything catastrophic, and then you obviously see them as well. And then there's obviously a ward team that's also taking guidance from us, but are also there if there's small issues that arise. And so there's always multiple people around. And look, in the private system, I work very closely with a non-invasive cardiologist, so to make sure that I'm not missing anything, we have a bit of a team approach where we both see the patients a couple of times a day to make sure that the little things are getting done and we're getting them out quickly.
Okay, one last one at this stage. They keep coming through. So at the moment, this is where we're at. Where is the usual insertion site?
Yeah, look, now it's almost 90 to 95% femoral. So through the femoral artery, that's where we normally go. Other places where we commonly go is the subclavian artery. So again, you just make a little incision, and usually with the help of a vascular or a cardiothoracic surgeon, we'll put that tube in and then feed the valve across. Like we talked about, the apical the apical approach is really falling out of favor. Occasionally, you can go straight into the aorta, but we've only really done one of those in the last 3 years. And sometimes, there's a new experimental stuff, which is I'm keen to try. I haven't quite found the right patient. Is going from the vena cava and across the aorta, across to the aorta, making a little fistula and then closing with a plug. But that's really for people that have no options. So we haven't really encountered that yet. And usually we're able to get away with either subclavian and predominantly femoral.
Okay, terrific. Well, listen, that's all the questions that have been sent through at this stage. I would just invite again, if you do have any final questions for Dr. Yudi, please feel free just to send them through. Dr. Yudi, is there anything else, I guess, for our doctors, our GPs who are, with us this evening? Are there any sort of final remarks or any final advice or thoughts that you can share with us?
Oh, perfect. Look, thank you again, everyone, for listening in. It's a bit strange in this Zoom world, but thank you for all your questions, which have been fabulous. I guess there's only a couple of key things that I want to relay to you. Firstly, is that severe aortic stenosis has a terrible prognosis. So when you've got a patient with that, seek help, right? I think you need to refer that on to ideally a valve center. Like, here's all my details. I'm more than happy to be contacted at any time. I've got GPs and other cardiologists that just call me and say, what do you think of this patient? And we see them very quickly, either at the Austin or in the private rooms with the structural heart coordinator, almost straight away, because these are medical emergencies and they need to be dealt with quickly. So the first thing is recognize that. And secondly, if you're going to refer, I think it'd be ideal to think about referring to somewhere where there's proper governance. So all the options are on the table for that patient. So there's, different people would have different biases, but there's so much technology and there's so many different experts in different areas of cardiology, of structural heart cardiology and cardiothoracic surgeon, that it is important to make sure that the patient has all the offers, all the potential treatment options for them. And it may not be the TAVI, but it would be, it's good for them to know exactly what's out there.
And I think too. Sorry.
Age is no barrier. So age, don't be ageist. If they should still be considered if they're 80s and 90s, and we do say no to them. But I think it is important, and it's usually the family that want at least those options to be discussed.
And I think a couple of the key takeouts for me from this evening is certainly making sure that you are looking at all the options available. It may not be TAVI, but not just being caught up in the idea that you may need open heart surgery or one of the other options there. It's really good to get that team approach.
100%. Yeah, look, that's I think that's revolutionized cardiology, and I'm hoping it's going to creep into other areas of cardiology, because I think that's how we get the best results for the patients.
And the other thing that, I guess I've really appreciated learning about as well is just how, I guess, short or how quick the recovery for the patient is as well. How quickly they're back on their feet and just doing, well, not even doing normal life, but doing better than what they were.
Yeah, no, look, it's revolutionary. Like, this is when I was doing my training, this is what you could see in the horizon. So that's why I was drawn to it immediately. Patients usually, they feel so much better, and they're so very grateful, this patient population. in their 70s and 80s, and they're still, you know, if they're mentally very good, they still have a lot of life in them, and they don't want to be restricted. So it's a very good option for them.
All right, brilliant. Listen, thank you very much for your presentation and for answering all these questions, Dr. Yudi. So for everyone who has joined us this evening, thank you as well. Thank you for your time. Thank you for your questions and the discussion that we've been able to have. On the screen, you can see the contact details for Dr. Matias Yudi as well. If you have any questions, feel free to just get in contact with him, or you can also email webinars@medcpd.com, and we can forward that through to Dr. Yudi also. We will wrap up now. We're actually finishing right on time, which is excellent. And we'll wrap up now. When you do leave this webinar, you'll be taken directly to a feedback page, and we do invite you, please give us your feedback if you found this useful, or if you have any ideas of how we can improve next time, please let us know. It's only a short form, and if you can provide that feedback, that'd be terrific. And that concludes our webinar for this evening. Thank you very, very much, and hopefully we'll see you again in a little while.
Thanks, Jason, for organising. Thanks, everybody, for attending. Really appreciate you taking the time out.
Brilliant. Thank you very much, Dr. Yudi. Good evening, everyone.